Thank you. What a wonderful group. I've enjoyed meeting with all of you so far. As I told my group, I live in the state next door. So I'm in Pennsylvania, actually on the Philadelphia side. And I am a senior manager with FFT. And so I thought I would give you kind of a real quick overview along with kind of what does the model actually do, because I think you can look up what is FFT anywhere, but I thought it might be helpful to do with something a little bit clinical. I just put my timer on. I'm a talker, so I apologize. But feel free to yell at me if I'm going too long or over time. So, all right, so let me open this up. There we go. All righty. So my hope, like I said, is to tell you a little bit about us, the model, and then the criteria, because I was thinking that might be the best takeaways for today. So FFT has been around for a very long time. In fact, one of the oldest states to do FFT is actually Ohio. In Lima, Ohio, actually did the first in-home version of FFT, because FFT has been around for a while. Back in the 80s and 90s, it was mostly an in-office like everything else was. But at this point, we have a lot of research. We have more than 50 published independent studies. We have an impact on the whole family. So we treat the whole family, not just individuals. And our overarching goal is always to keep youth and families together. We're a short-term, structured, intensive family therapy intervention that really looks at the family dynamic and the family system to address adolescent behavior problems. Our model developer, Dr. James Alexander, always had this idea in terms of his experience as a social worker and working with gang members, that if we try to treat somebody without the system, we kind of set that person up for failure when we put them back into the system, because the system hasn't changed along with that young person. He also saw, and this kind of comes out in the model, this idea that the system also holds the potential to help that young person versus seeing the system as part of the problem. The target population for FFT is 11 to 18 years old, young people who present with behavioral and emotional problems. We work across many different systems, not just juvenile justice, as most people think. In fact, I started in 2001 in the Lehigh Valley of Pennsylvania doing FFT for our child welfare programs. On average, FFT is about, I will tell you, 14 sessions over 4 months. We really design the model to the risk and protective factors of the family. And so it's not a one size fits all. It's really an analysis or an assessment of what the needs are. And that's how we design the model, intensity and frequency, but it is a weekly model. And then we have that freedom to go, longer or more often, or short sessions over many times each week. And we really provide the service where it's convenient for families. So most people say, well, in-home is always convenient, but there might be some situations where it might be better to do in office or go to a neutral place, in terms of safety and for other reasons. And we're the training organization. We provide implementation support. We do all the training and consultation for your Ohio teams. And because this is a larger state initiative with Families First, I'm actually involved very closely with the center to help with QA/QI. And I do a lot of work with Medicaid, trying to protect the model, but also work nicely with Medicaid so that we can have long-term sustainable funding. As a training organization, we're a small group. I say small and mighty, 35 trainers and consultants who really partner with teams versus have kind of this top-down oversight. Our idea is to grow excellent therapists who can work with families, with youth and families with high risks and needs. And then as we work with our sites, we really try to help them have more localization or ownership. So in the first year of any new site, we do all the supervision, but then in year 2, we take somebody on the team and train them to provide the supervision so that there's more local ownership. And the other great thing is that our training program has actually been evaluated, which is something we don't always think about. Can we train up therapists to have good fidelity? And we know fidelity equals lower at placement, better improved family functioning. And of course, overall, if we can keep youth out of placement, then we have cost savings. We are international at this point. When I started, there were like 20 sites in the United States and a site in Sweden. We now have 350 plus sites across many different languages and countries. I always say cultures. FFT is delivered in many different languages. We serve about 50,000 families each year. We have sites that have been providing FFT for many years, 20 plus years. And Ohio has quite a few teams that have been around for a very long time. And we work, like I said earlier, across many different systems. So our exportability across those systems is wide. So in terms of the clinical model, I always start with a framework. And I always think of FFT in terms of what are the families, or I should say, how do we meet families, right? When we first start our work with families, how do they meet us? And we always think about this notion of we should expect that families probably don't trust us, may not see us as credible, may have had a history of many different programming that didn't seem to work, and where there were many change attempts, which ultimately resulted in a sense of lack of success. Either because it was told to them, you have not been able to, or this young person hasn't done well in any program. But FFT really takes the stance that we are accountable, right? We have to make this worth their while. We have to motivate that family. So it's something very different. I'm a family therapist by training, whereas when I was trained back in the 90s, families have to be ready. Families have to want to do this. We kind of understand those who have been in multiple systems are probably burned out, don't see us as credibility or trustworthy. So we have to be the ones to partner with the families and get them interested. We know that the families we work with often are at elevated risk. Otherwise, they would probably be in less intense outpatient type services. Oftentimes families that experience lots of conflict with very little resolution. So there is a sense of hopelessness, as well as, kind of that level of crisis, what we call negativity and blame, that's really heightened. We know in families that have been multi-system involved or years and years of system involved, may drop out quickly from interventions if we don't do something different and quickly. And so we really do build in intensity in the beginning, to engage them to stay. We also build in crisis management right off the bat. Some of the early techniques we use really work on reducing family defensiveness, and underlying a lot of crisis behavior is that sense of negativity and blame that really kind of gets heightened. We know the families we work with are most likely lacking in resources across many different areas. And so understanding that as we go in is critical. We also know that when we have a behavior or an emotional problem, it's a symptom of a larger system. As I said earlier, things don't happen in isolation. They happen within a system. They're often held within that system. So a youth who might present, with truancy, we know it's more of a family issue. And so we understand other family members, siblings, caregivers may have other concerns that we're not just going to ignore, but work on as part of that system. The family becomes our client. We know that oftentimes the families we work with are seen as needing to be told what to do, but if that worked, we wouldn't be needed, right? So we work really hard to have them understand and buy in and be engaged and motivated to do something different. Parents often have given up that we work with. In my own backyard, Philadelphia, we get youth from the family court where parents have said, I give up my child, I can't do anything. I don't know what else to do. I'm scared. So we expect, like I said, that level of risk. But at the end of the day, is a family. And our job is to be curious about that family. We are not the family expert. How we raise or do things in our family is not how other families, in fact, could hurt other families if we kind of take that approach that, oh, it works with this family, so all families should do this. We really use a model that is evidence informed. All the techniques are tested. And the idea here is we want to be humble and curious about the family. They are the family experts. We are the experts on change. And we really start from a strength-based protective factor focus, trying to understand through their story, resources, internal resources that they may not realize they have, which are strengths. And when we're in a problem, we get stuck. But when we can see a different way of looking at the problem, there are more solutions for us. We really use a family systems theory combined with behavioral approaches. We are based on a theory of, people say functional family therapy. Is that because you're trying to get dysfunctional, functional? Actually, the function comes from this understanding that family members function in ways to get their needs met. And sometimes they're doing that because they're trying to have power or influence or control things, or create distance or intensity or connectedness with others. And so we spend some time in the beginning of the model understanding that. And then once we understand the functions of those behaviors, hey, when mom does this, it really pulls in dad. When youth does this, it really pushes grandmother away. We can then design an intervention that matches to help people get their needs met, because we understand that people have predictable patterns. They go certain places when there's problems. And so if we can understand those roles, our intervention can be designed to address family interactions that have kind of continued in a pattern that results in maladaptive behaviors or the referral problem as well. We're a phase-based model. Each phase has its own assessment, intervention goals, strategies, and techniques. So our therapists learn, here's the assessment piece, here's your goal during this phase, and then here's strategies to help you reach that goal. We really start in the very beginning to get credibility. That's through our engagement with families, have them experience services differently. And then we move to having them experience each other in a very different way. That's our motivational context. Once we're there, we can go from relational to more structured, more directive, literally teaching them new skills. And then we end with an ecological, I should say, we always have an ecological focus, but we end by really looking at how do we help them generalize their change. The model is short-term, as I noted earlier, and it's 100% family-based. So I always talk about this in terms that when we're with the family, we're using a quality tested model, and we don't do any individual work. We always do family work. And I mentioned earlier that we really design the intensity and frequency based on the family risk and protective factors. This is a quick visual of what the model looks like. 5 phases. We don't go back and forth between phases. We always move forward. And we do that in terms of understanding how the family interacts start to shift, as well as we use assessments to get feedback from families to make sure they are ready to go to the next phase. Real quick, the phases, we engage therapists, or excuse me, engage the family into treatment by being responsive, as I mentioned earlier. The motivation phase is where we really try to change focus, change meaning of these negative experiences and patterns so that they can be more hopeful versus feeling stuck in kind of like a problem focus, right? Versus seeing other ways of understanding why we do what we do in the family, because in that, like I said earlier, will open opportunities to do more interventions. Why we're talking with that family and understanding kind of their experience together, we are assessing those functions, those payoffs. Why do people do what they do within this family? Well, guess what? It really pulls in somebody. It really pushes somebody away, right? For example. Then the next phase is behavior change, where we really now have the freedom to do whatever it takes, right? To reduce and eliminate those problem behaviors. That could be using CBT techniques, behavior modification, problem solving, communication skills, whatever matches to the family to reach the goal to have a different pattern with a different outcome. And so we definitely, all of our behavior change interventions are active, participating. We role play, we test it out, we give feedback and coaching, and we have them practice with us and then on our own. And usually by the time when the family is starting to do it on their own, we recognize we can move to our final phase, which is generalization, which really looks at how do we maintain this change that they've experienced, because we won't always be there to facilitate it. How do we help them generalize it to other systems? If I've learned how to negotiate with my youth, or my youth has learned how to negotiate with me, can we use those techniques with my boss, with the youth coach or teacher that they're struggling with? And we develop a relapse plan and provide and connect the family to other support, be it professional supports, or maybe even natural supports, other family members, community members who could help that family, say when mom needs a respite whereas she would usually get overwhelmed and use. If we can find a way for mom to figure out what are her triggers, what are the symptoms, pull in that neighbor who typically does step in to help the family, but do it in a way that's planful, and then mom goes to an AA meeting, for example. And that's how we do that. And then after we close, we do offer families booster sessions because life happens that can shake up kind of the system, and we can get them back on track in a couple of sessions. Just as a quick visual, I always like to do this one. Think about it in terms of FFT really tries to strengthen the family relationship to crowd out negative relationships or negative influences, right? Because often when we start working with the young person, those negative relationships or negative behaviors, influences have crowded out the family. They're really the value system of that young person. And what we want to do is really strengthen the family as a place of belonging. In terms of criteria, 11 to 18 years old, sometimes 10 years old if they're in the system, sometimes youth turn 19. We still do the model. We need at least one caregiver to do the model and one youth as a minimum, but we work hard to figure out who the other, we call them major players, are to be a part of the therapy. And we kind of own that and see that as our work. We, as I said earlier, work with a range of adolescent behavior, referral, and emotional problems, as well as underlying anxiety and depression and substance use, and of course, family-child conflict. In terms of overall criteria, the youth needs to be in the community, ready to go into the community. And again, we're as a program that's focused on emotional and behavioral concerns. That is what the driver is for the referral. And we really work quickly to reach out to families and start therapy as soon as they're referred. We try to avoid having wait lists at all costs because we know that can create more stress for families. In terms of what's not appropriate, younger children, we're a clinical model. It requires cognitive thinking about behavior. Youth who are more appropriate for psychiatric settings. We're not a sexual offender treatment model. And a youth that really doesn't have a family or is really looking towards independent living. We need them to have some system to work within. Whew. And there is my quick didactic. I have, of course, for you, our website, which gives a lot of good information from where we are in the world to some of our model adaptations and who we are. I will stop there. So thank you.